Good evening. My name is Carol Ann Schoenhut, and I'm your host today on Womanly Wise. On Womanly Wise, we believe that knowledge is empowerment. Following our series on breast cancer, we have as our guest today Dr. Kirk Brendel. Dr. Brendel is a plastic surgeon associated with Graduate Hospital both in Philadelphia and City Line Avenue. He's also associated with the famous breast specialist, plastic surgeon, Dr. Julius Newman. When a woman goes through a mastectomy and certainly is told that she must face a mastectomy, she has many, many decisions to make, one of which is reconstruction. What are her options if she opts to go through reconstruction?
She basically has 4 different options, going from the least involved to the more involved. And first, we can place an implant underneath the skin in the area where the mastectomy was. The second option, if she didn't have enough skin, would be to place an expander or a balloon which can blow up the skin. And then an implant can be placed under that. The third option would be to take a flap from the back and move it to the front based on a muscle pedicle, and to fill in a defect here. And the fourth way would be to take a flap of skin from the lower abdominal area, bring it up underneath the skin, and place it into this area. Those are basically the 4 primary ways of reconstructing a breast.
Do you learn all of this in medical school?
Well, you may be exposed to it in medical school, but after you do general surgery, oftentimes you'll be exposed to it. But primarily in plastic surgery training is where I learned it.
Do you have a preference as to which one you would recommend?
Yes, I like to start first with the simplest method. That would involve placing an implant through the incision and then suturing it and just having a nice implant in the area of the breast. However, it's very important when you do an implant to look at the opposite breast, because that becomes a very real consideration. If a woman, for example, has a small breast, we could place an implant here and match the 2 sides. For example, she may not want to touch the other breast. She may not want to have the breast reduced or produce any scars on this side. So if she had a very large pendulous breast, perhaps we don't have enough tissue here to be able to put in an implant or to be able to put in a tissue expander. So it's important also to look at what the situation is with the other breast. I primarily first will opt to put in a breast implant, and if I don't have enough tissue there, I will go for my second option, which would be to make an incision in the area of the previous scar and to place a balloon, called a tissue expander, in the area of the breast, and then slowly increase the size of that expander over a 3-month period, and then remove the expander so that I would have approximately 200% more skin than I needed. And then I would take an implant and place it underneath this area. And then that would create a more natural looking breast.
When you do the temporary expander, is that filled with saline or is that filled with the silicone gel?
That's filled with saline.
Oh, good. Can I talk to you about TransFlap? Because I know a lot of women who have done this primarily because they want to remove the little heaviness around the middle of their stomach. What does a woman need to know to make an educated decision whether or not to do this TransFlap?
Well, the TransFlap is quite an involved procedure. First of all, I think that not everyone is a good candidate for a TransFlap. That would be the first consideration. The second consideration would be whether the patient actually wants to go through a major procedure, which can take oftentimes up to 6 or 7 hours of surgery. The third major consideration would be, what would you do with the opposite breast? You may have to reduce it in order to match it to the opposite side. However, basically the tram flap, or what's called the transverse rectus abdominis muscle flap, and I have a picture of it. Would you like me to show that?
Absolutely, because this is a very involved operation.
This is a picture of a tram flap. What it essentially is a piece of skin here, which is actually the same size piece of skin that you would take when you do an abdominoplasty or a tummy tuck. And you use the muscle, this vertical muscle called the rectus abdominis muscle here. You use this as the blood supply to the flap because we're going to be lifting up this piece of skin right here. And then we're going to be taking that piece of skin and tunneling it underneath this area here to place it through the previous scar so that we will essentially, if I can show a second picture, here we are moving this piece of skin, placing it up in here. We're creating almost a natural appearing new breast. This procedure is advantageous because it avoids using any implants. Some people may not want to have that. However, there are some problems with the tram flap. First of all, because of the blood supply comes inside of this muscle, and through the muscle, arteries come through the subcutaneous tissue and into the skin. Primarily, this area is very well vascularized. However, coming out to this tip in this area here, there can be some skin suffering. So there are complications involved with doing this.
So you mean the skin might die?
The skin might die, which would cause a small defect in the area and sometimes weeks of healing in that area. You'd have to go back to your surgeon on a daily or every other day basis to be able to remove, having to remove this tissue which has died and wait for it to scar in. And then after that, you have another defect that you have to take care of as well, which would involve another surgery. So this is not a simple flap that someone should think, well, now I've had a mastectomy and I want to do a little tummy tuck at the same time. It's not a simple thing that I think that everyone should be trying to consider as their first option. However, today, as we have improvements in certain medications that can be given systemically to increase vascular blood flow, that can help to improve the vascularity of the flaps. Secondly, we have a technique where we can take a small piece of the muscle from the other side and do a microvascular anastomosis to the blood vessels here in the axilla to supercharge the flap or bring enough blood supply into this side. And you need to have a team of physicians who are used to working together on a service that has done many of these types of flaps in order to have a good and successful result. I personally believe that if you do this type of surgery once a month, that it's possible that you could have complications more so than a particular plastic surgeon who does, say, 5 a month or 10 a month, where he would have a team that could work together, would have more experience, and would be able to complete the procedure much more rapidly. So I think it's important to know who your surgeon is. Does he perform this type of more advanced surgery more often than say, putting in an implant?